I am Amy Krambeck, and I am from Northwestern in Chicago. I don't know how I follow Jay with the firecracker to the groin or the wooden piece through the groin, but I'll try. so, so my job right now is to tell you how great HoLEP is, and then in 2 hours, I'm going to tell you all the things that can go wrong. So this one's biased, the next one will be biased the other direction. So these are my disclosures. I do work as a consultant for multiple different companies, and I'm on the DSMB for Europrene. The hydrate study's over with the NIH, and these are our learning objectives. So I think most of you in the room know what HoLEP is. So when I first started giving talks on HoLEP, very few people were familiar with it, but basically it is a simple prostatectomy, but it's all done endoscopically through the natural urethra or natural orifice. The indications for HoLEP are vast. Some people think, oh, it's only for large prostates, but actually there is no size limit for HoLEP. So there's no prostate that's too small, and there's no prostate that's too big to be treated endoscopically with this technique. Basically, you need a man with severe enough BPH symptoms that they're looking for treatment. So the max amount of tissue that I've ever removed is 600 grams, all endoscopically. So that's like taking a baby out, like a baby's head out of someone's urethra. And he urinated great afterwards. But the least amount I've taken out is 1 gram. So somebody had a very tight, high bladder neck, and they needed an enucleation to get that tissue out. So because it's such a vast indication, my workup is extremely simple. I always want some type of numerical value to their symptoms. So I usually get an IPSS score. I get a Michigan incontinence score because a significant amount of men have baseline incontinence that they don't talk about. Usually get a SHIM score to assess their erectile function. I want some type of post-void residual, maybe a uroflow. But the big thing is, if you have a man who is of the age and health that he is a candidate for a radical prostatectomy, you want to make sure you do a thorough prostate cancer workup. If they're so sick that they wouldn't get a radical prostatectomy or they're older, then you can go ahead and do the procedure knowing that they would get some type of other treatment for their BPH. But if you think they're going to get a radical prostatectomy, you don't want to give them a HoLEP ahead of time. That's wasting a surgery. So, I do the PSA rectal exam. If the PSA is elevated, I get an MRI. If the rectal exam's abnormal, I get an MRI. If they're negative and everything's normal, I'll usually get a CT or an ultrasound for sizing, and then I make sure that they do not have an infection. I rarely get UDS. I rarely do cystoscopy this far into my career unless I'm concerned about stricture. To do the HoLEP surgery, you can do it with a 22, 24, 26, or 28 French scope. Any size will work. If you get below 24 French, you can't morcellate with that scope, so you have to switch out. I prefer 24 or 28, depending on the patient. But regardless of what you're using, you need something to stabilize the laser fiber, because the holmium laser is very acoustically impactful, so it will vibrate as you use it. So you need something to stabilize it. And sometimes just getting that catheter in the ring is the hardest part of the case. So it can take some time to get it in the stabilizing ring. But does the sheath size matter? You see a lot on Twitter about smaller, micro HoLEP, or big HoLEP's bad. So we did actually a prospective randomized trial where we randomized patients to either have a HoLEP done with a 28 French scope or a 24 French scope. And then we followed them at 1 week, 3 months, and we're about to publish our 2-year data. And the groups were identical. There was nothing different with regards to size, age, workup, symptoms. And we really found no difference in outcomes. So morcellation was the same, enucleation time was the same, procedural time was the same, but we were more likely to get the catheter out, and we were more likely to discharge the patient that day if we used a larger scope. There was no difference in bleeding, ER rates, incontinence rates, stricture rates. So we concluded that the larger scopes may help facilitate surgeons to achieve that high same-day discharge rate or voiding rate. But there was no clear difference in efficacy or safety between the two groups. And usually I reserve that 24 French scope for men who have smaller urethras, prior urethral stricture repair, penile prostheses, or small prostates. So the jury's still out about what's the appropriate size. I personally think that the larger scope lets the bladder decompress more. So it's not getting over distended, and that's why we have better success in same-day voiding. So regardless of the scope that you're going to use, these are the tools that you need. So you want to first dilate the urethra. I know the recon surgeons in the room, they all, oh my God, you're dilating the urethra, but we do want to dilate the urethra so that the urethra is nice and loose around the scope. And occasionally, if they have meatal stenosis, we'll utilize an otis urethratome just at the distal meatus. How many people in the room have seen otis urethratome? Oh, this is so nice. It's so much better than talking to residents who have no idea what this is, but it's a great device when the urethra is tight distally. And then when I start my HoLEP, I let the prostate tell me how to do the procedure. I don't go in saying I'm going to do 3 lobes or I'm going to do 2 lobes. I actually take a really good look and I look at the natural grooves. So if there's no median lobe, I might make a cut at 6 o'clock. If there's a small groove, then I might incorporate the small median lobe into a lateral lobe. If there's a large median lobe, I feel like it's much better to get that out of the way so that I have room to work. So I'll make 2 cuts to enucleate the median lobe. So this is how I would make my initial grooves. I've dilated the urethra, I put the scope in. I'm going from the bladder neck to the viru all the way down to the capsule. And so you can see that when I make these cuts, I'm actually touching the tissue. But I'm going to have to make this cut multiple times until I get down to that slick capsule. And the capsule has a very unique look to it. It's slick. You can see the vessels running transversely. You can see that the adenoma is actually fluffy, more like cotton candy. So you can tell the difference by how the tissue reacts to the laser. And now I'm down to that capsule that you can see the difference. So I make that cut on one side, and then I make it on the other side, and then I connect those 2 cuts. So I come back to the viru, and I'm going to do my upside down U incision. So I'm going to connect the 5 o'clock cut and the 7 o'clock cut. And as I do that, the tissue will naturally roll forward. Now this particular case is a 300-gram prostate, so really large median lobe, but you can see it's not bleeding much, and the tissue is naturally rolling up over my scope, and I'm using the scope to create traction countertraction. And if you can get that traction just right, you can actually see the line. This is the plane you would stick your finger in a simple prostatectomy to core out the tissue. It's very obvious once you set the case up right. And I think this is a great part for the residents to learn because it's simple. It's forward in front of them, not a lot of scope manipulation. Now I rolled that tissue into the bladder, and now I have to detach it from the bladder neck. So I'm going to cut in from the lateral sides so that I avoid the ureteral orifices and I avoid leaving a big chunk of tissue at the bladder neck. So now it's enucleated, it's in the bladder. Now on to the lateral lobes. So I start at the viru, I make a small incision in the tissue, and then I stick my scope into that pocket and I twist. So this is a clockwise turn on the right-hand side, and I'm using much lower energy here. I'll use a 2 joules and 20 hertz when I make this turn. And then I have to release that little piece of tissue, that urothelium that's attaching it to the sphincter. So I'm going to cut, and as I cut, I move the scope forward to create a little bit of a tag of urothelium at the 12 o'clock, which later I'll discuss how that helps with continence. But I'm just rotating around the adenoma, creating the plane between the capsule above and adenoma below. And once I've done the right side, then I do the left side. I incise the urothelium, I make the pocket, stick the scope in, and twist, this time counterclockwise. Then I lower the energy, and I'm going to release that adenoma away from the capsule, with very low energy. The reason I use low energy is not because I'm worried about damaging the sphincter. The depth of penetration is very low with the laser. But it's because if you try to use high energy in these tight pockets, it will char out and burn the tissue, and you lose your plane. So you lower the energy so that you can see your plane, and I release that tag. So what I've just done is I've released the whole apex of the prostate on both sides. We've got the median lobe out, so we're ready to move forward. Now we do the anterior plane dissection. So I have the adenoma below me, I have capsule above me, I have the scope in between, and I'm just pushing down on the adenoma, and I'm lasering back and forth as I work from sphincter to bladder neck. So this is a fun, fast part of the case. This is what makes people very efficient, by doing this part next. Then you come to the bladder neck and you see what I call the baleen of the prostate. So it looks like the baleen of a whale. It's up and down fibers, very easy to identify. That's the bladder neck. You're going to run into a little bit more bleeding here as well, but extremely easy to identify. And you will actually cut all the way into the bladder so that you've released the bladder neck. When you release the bladder neck, you want to drop those curtains down to make a very nice wide bladder neck. We're not trying to preserve ejaculation with HoLEP. We're trying to get these guys urinating and keep them from bleeding. Then we divide that tissue in half. So we divide the prostate into right and left lobes, so that you now have your 3 lobes completed. And that's very easy. You go from the natural lumen up to the plane that you've created anteriorly so that you have your 2 lobes complete. And this is also another nice thing for the resident to do, a very easy step for them. And then you just do the lateral lobes. It's very simple. You come back to the sphincter, you work that corner. So you've created the anterior plane, you work the posterior to lateral to connect that anterior plane, and then the tissue will just naturally roll forward. So most of my enucleations, depending on the size, take anywhere from 10 minutes up to 35, 40 minutes, but rarely ever beyond that, because I systematically use this technique to remove the tissue. You can also see that I do a lot of lasering, not a lot of pushing. I don't lose the plane, and I control the bleeding as I go. Then I will do final hemostasis. So I'll take the laser through the fossa, dry up any bleeders. It's very important that you have good visualization when you morcellate. You don't want to be dealing with a lot of bleeding, trying to figure out what's going on and stress. You want to have it nice and dry and go through and clean up those bleeders. And then we morcellate. And I'm going to go over that in the next talk, so I'm not going to have you watch that. This is the color of the urine at the end of the case for most patients. It's very clear. It looks like CBI tubing. This is what it usually looks like after they've gotten up and walked. Might be a little bit redder depending on the patient, but it shouldn't be that bright red blood that you see with other procedures. And then this is what HoLEP looks like a year after surgery. You can see why we get these really good results. It looks like a simple prostatectomy. So when we talk about outcomes of HoLEP, we have to think about measurable outcomes and the complication. And we're going to look at the good outcomes in this talk. So I love HoLEP because this is the most widely studied surgery of any BPH procedure available in the United States. It's had more randomized clinical control trials, more meta-analyses. I think we even have a meta-analysis on the meta-analyses, and it always does well. It has short catheterization time, short hospitalization time. But this is one of the meta-analyses that I really like. And this is a comparison of TURP to HoLEP. I think HoLEP gets a bad rap because people say, oh, it causes incontinence. But if you actually look at it, it doesn't. And when you look at HoLEP to TURP, you can see that you have shorter hospitalization time, shorter bleeding time, shorter catheterization time, less blood transfusion, all the things we've talked about. But when you look at the transient incontinence rates, it's no different between HoLEP and TURP. And the persistent incontinence rates are not either. The only difference in these early studies is that HoLEP took longer than TURP to do. So I think anything that physically removes tissue runs that risk. Those studies were old. Now fast forward to 2023, 2024, and we did a comparison at Northwestern where we looked at HoLEP patients and compared them to TURP patients, because we still have quite a few providers that are still doing TURP. And when we compared the two groups, there was no comparison. So we got more tissue out with the HoLEP. They were bigger prostates. The procedure time was significantly shorter, and the patients left the hospital. So I think with current era technology, you can get these patients out of the operating room in around an hour, and you can get them out of the hospital within a few hours. But I think what makes HoLEP so great is the durability. So one of the early studies done by Gilling, where they randomized patients to either HoLEP or TURP, they had 7-year follow-up. So they looked at these patients every 3 months for 7 years. And over that 7-year period, the HoLEP patients consistently had better AUA symptom scores, quality of life scores, and flow rates than the TURP patients. Furthermore, over the 7-year period, 3 patients in the TURP group needed a repeat procedure, whereas none of the patients in the HoLEP group did. But if that study does not convince you, this is a database study out of Canada that looked at almost 1,500 patients, and they had follow-up for the majority of these patients out to 18 years. And over the 18-year period, their PSAs remained low. They had a 2% bladder neck contracture rate, a 1.5% urethral stricture rate, and 1.4% of the patients needed another surgery over 18 years. And most of those were small glands that the surgeon had done during his learning curve. So why do I think it's better now than it was before? I think it's really pulse modulation. So with old holmium laser, you had the laser that just went forward. But with pulse modulation, you have a first bubble that creates a vapor channel, and then a second bubble that shoots through that vapor channel so that you get more energy delivery to the tissue. And it's not just me that thinks this, but it's many different surgeons who have studied this that shows it increases your efficiency. So it decreases your enucleation time, it decreases your hemostasis time, and you have less laser burn back. So it's definitely more efficient. And this is just some videos that I did where I used a regular holmium laser and then I used the pulse modulation. And you can see with a regular laser, I'm really having a hard time controlling the bleeding because I'm creating these tunnels into the tissue. And it's just hard to get that laser energy to spread out and control these big vessels. So you can really dig a pit down into the capsule trying to control these bleeders. But if you fast forward to pulse modulation, the energy spreads out, so it's easier to coagulate. And pulse modulation is now available with multiple different companies, Cook, Quanta, BSC, but it's really great technology. And if you use the comparison, don't think this is TULIP, don't think this is TFL. It's completely different. So this is a TULIP, true thulium, and then this is me doing a TFL, and this is me using pulse modulation. So it's kind of the best of both worlds in that you have that great acoustic energy to dissect out the tissue, but you don't get the charring effect. So when we started using pulse modulation, we noted that we were able to actually discharge the patients home same day. And really the only difference between patients spending the night and going home the same day was the use of the holmium laser. We also found that if we sent them home the same day, they were more likely to void post-op day 1 than patients that spent the night in the hospital. So we're like, why are we even leaving the catheter in? Let's do the voiding trial before they leave. And sure enough, we found that when we took the catheter out before they left the same day, 90% were able to urinate. And so we were trying to figure out why that 10% couldn't urinate. And we looked at multiple different variables, surgical variables, patient variables, anesthesia variables, and we never really can figure out why 10% can't urinate the same day. We're still, that's a black box to us. We do know now that anticoagulation is probably not the best patient to try to send home the same day. So we do have great results with low transfusion rates, low bleeding rates, but they do have a hard time urinating the day of, and they do have a higher 30-day complication rate. When you hold anticoagulation versus continuing it, you can still have the same good outcomes as well. So the same day, I'll end with the same day discharge pathway. You want to communicate with your anesthesiologist. You want to avoid intraoperative narcotics, use an LMA, and avoid muscle relaxants. Make sure that you control bleeders as you go, and you want to control bleeding before and after you morcellate. Thank you.